pain is not normal, if you need to take more than 1 to 2 pills of AIDS or ibuprofen or whatever, and the pain is bad, and that's not normal. No one can tell you that's normal. Because one of the most important parts is if the patient has history of surgeries, because most of them has.
Yeah.
And most of the patient of 42, 45 years old that has a long history of endometriosis have 2 or 3 surgeries.
Yeah.
So if you're going to plan a surgery for them, you will try to do the last. So,
welcome guys back to my podcast. I'm here today with Dr. Santiago help me with this one, man.
Artazcoz.
Yes. Guys, leave in the comments if you can say his name correctly. I'm going to call you Santiago for the rest of the podcast.
That's perfect.
Santiago is a minimally invasive specialist in gynecology, and he has a special interest in both endometriosis and Isthmocele repair, and I've seen many of his surgeries he's showed me live, and they're absolutely amazing. I have many patients come in asking specifically about those 2 questions, and because there's so many different ways to treat both of those conditions, and people tend to be very opinionated or, given the different clinical circumstance, treat them very differently. I wanted to talk to you today about how you approach both of these conditions and help guide our patients when I send them to a specialist like you, what's going into your decision making and why you choose what you do.
Okay, sounds good.
Santiago, for everyone here, tell me about yourself. Who are you and why did you go into MIS?
Well, my name is Santiago Artazcoz, as you said. I trained in Argentina, where I was raised and born. I finished my residency in 2011. I had one of my mentors. He was very into minimally invasive gynecology surgery and also endometriosis. So he maybe put that flame, or something that gets me very interested about this. So I met this physician that I look at him when he was teaching some didactics in a small course that we take in Corrientes of us. And his Revas Bochorisvili is very difficult to say, the last name too. So this physician, he's from Georgia, but he's practicing in Clermont-Ferrand in France. And I loved the way that he did surgery, and I want to do a rotation when I finished my last year of residency. So I wrote him to start this fellow, because at that time there wasn't actually a fellowship of minimally invasive. So I went to Clermont-Ferrand. I stayed there for a month. I saw a lot of things. We suture chicken every day in the pelvic trainers. So every day we suture chicken, of course, that chicken, like breast and stuff. And after that, I have a friend over there, and he said, this is great, but you should go to Taiwan. They have at least 13 ORs just specifically for gynecology, and you should come next year. So I went back to Argentina. I do my chief of residency, that it's a separate year, it's an extra year. So I did that in Argentina, and then I meet this guy in Taiwan, in Taipei. But there's a place that was close to Taipei, 1 hour, that's called Linkao. And they had this massive, this huge place where they do a lot of surgery. So I spent there 3 months, and that was another very, very nice experience.
Because now you practice in 3 places. You practice here in Miami, but also Argentina and Taiwan. How is the practice setting different?
Well, I just started in the US, so for me everything is new. I'm just discovering how you guys do the things here. In Argentina it's very straightforward. I mean, we try to follow up guidelines. We try to follow up the best healthcare for patients. There's no much minimally invasive training like for every gynecologist. I think that to do a very good surgery, you need to have a very good training on that. And sometimes my opinion is that if you do the specialization in one area and you stay most of your time doing mixed cases, probably you will get better training and you will get better results for your patients.
So I agree with that. I think the more you do something, the better it is. The downside I've found in general is the more people specialize, for patients, it's harder to go from one place to another place, which is part of the reason I'm making these videos. You may choose to do something that I may have not had that specific training in. I want my patients to hear from you, hey, this is how the care is transferred.
Yeah.
Because I think that is the one small part I think that lacks, and I think that's why I wanted to have you on. Doing these videos can help fill that gap.
Okay.
How was that in Taiwan? What was
Taiwan
that like?
was a very crazy place. I mean, everything was weird. They don't even speak English in the streets, so of course no Spanish, no? So when I was something to eat or something, I just point on the picture. I want this and that. But they're very careful with the patient. They were very on the patients, even if they had so great volume. One of the interests is that Asia is huge in healthcare, but they didn't publish because they didn't know English at the first time. So they do there's a lot of surgeries that they do first than Occident, than West. They call us West.
Yeah.
So, and that's maybe because they don't have the tools to publish. So I have a lot of respect about Asian physicians and the Asian healthcare. I learn a lot of them. I learn notes. They do a lot of 12. They do the notes surgery.
For people listening, I know what you mean by notes,
No,
but they're
right.
probably thinking you're taking notes on a paper.
Yeah.
Notes is a very specific surgery, like an endoscopic surgery, like laparoscopy, that is through the vagina.
Exactly.
Which is, now we're seeing that a lot more in the US. So imagine people are going crazy about the robot because it's minimally invasive. Imagine if you had no incisions on your belly for a very large uterus. So these are the things that they're innovating.
Yeah. And there is like 12 years ago.
It's incredible.
So, and they're like very used to that. Also, I saw a lot of like tissue extraction for very small incisions with all this like the exact technique that we discussed the other day. They're very into that. So it was a great experience. I mean, it was the first time that I sit down on a robot. They have like a Da Vinci over there, and it was the first time that I sit down there. I mean, it was a really great experience.
Amazing. What was your day-to-day? You'd wake up.
In Taiwan?
Yeah.
I wake up every day and go to the OR. There's a director of us. I spend probably 10 hours, depends on the day, but between 6 and 10 hours, depending on the day. And then they try to get us published for them. So we have roundings, we have meetings for publishing, and we have the OR. So they're very gentle with us too. So that was a great experience for me.
That's great. I wanted people to hear. Sometimes you go to these places and the amount of volume and just repetition after repetition that you get really sharpen the sword to just polish your skills.
But even when they have this big volume, they just was very into the patient, was very close to the patient. Something that sometimes you don't see often.
Yeah. So let's go back. Then you went back to Argentina, and then you did your chief year, you said, and then you started to practice.
Yeah, after that I started doing endometriosis because my chief went with Donès in Belgium to do also some subspecialty on endometriosis, and we start together doing a lot of cases. And after that we get into the Argentine Society of Gynecology Surgeons, and then in the Argentine Society of Endometriosis. And then also we get together with groups of patients that they made to fight for rights for endometriosis, to get more visibility. So it was a journey on this disease and this pathology. And of course, it's a disease that you really need to like it to get into, because it's difficult and results sometimes are not what we want to expect.
Yes, and it's with both of these things, endometriosis and isthmoceles are two pathologies that some women unfortunately deal with many years before a diagnosis. They don't have a cause. A lot of times, unfortunately, the patient is put down going, you're fine, you don't have any issues, and then later just to find out, hey, oh, you had something that was actually causing all these problems. And until recently, it was harder for diagnosis. They would just tell people, take some birth control and be done with it.
Exactly.
So, great. So then you tell me about your practice in Argentina.
I work in Sanatorio Finocchieto, one of the private hospitals over there, one of the leading technology hospitals, and also in the Naval Hospital. That's my hospital, it's private, but it's more like a hybrid sometimes. So that's my 2 hospitals over there. I work in both places the whole week. I have ORs on Monday, Tuesday, Thursday, and sometimes Friday. I get my office. I do gynecology over there. I didn't do any OB for the last probably 10 years. And I started now again. Yeah, because I'm retraining here to have my license to do residency again.
Talking to you about your patients, really, and also with the doctors, really took the time to talk to the doctor that sent you there, made sure, hey, sent them a report back that this is what's happening with your patient, and making sure they didn't feel like just a number. Because like you were saying, some places with a high surgical volume that you see, they're very good at what they do, but they works like a machine. Versus, I mean, yes, you work like a machine, but...
Especially these 2 diseases or pathologies, one of the things that are common between them is that the treatment is not written in a book. Mm-hmm. We call the endometriosis surgery tailor-made, because for each patient is different. And if you don't get a connection with the patient, if you don't ask what she needs, if you don't ask what she suffers, you probably don't do the best treatment for her, because it's not the same treatment for the same pathology from the same patient. Mm-hmm. Everything's changed. So you need that connection. And I respect a lot of the referrals because I live because of referrals at that time. So any physician that sent me a patient for evaluation or for surgery, I was in very close contact with him before getting the patient to my office, and then with the patient to see, okay, what do you expect of this visit? What do you expect about surgery? Or what do you expect about treatment? Because there's a lot of patients that I keep following that they don't need surgery. Mm-hmm. They just need follow-up. And the treatment in endometriosis is so wide that sometimes you can say surgery is the last call for treatment.
Yeah. So let's do this since we're talking about endometriosis. When a patient comes into your office and they're referred to you because of pain, and we're assuming something along the lines of endometriosis, how do you originally evaluate that patient?
Well, first of all, one of the most important things that we need to know about this disease is that it can be completely asymptomatic, almost 40%.
Yeah.
It's very, very prevalent. I mean, probably 10% of the population, fertility age population, has endometriosis. And it takes 5 to 10 years to diagnose for the diagnosis. And also, if we are facing fertility problems, between 35 and 50% of the patient has endometriosis. So it's much more common than we thought. So the first thing that I start with my patient is asking, how is she? If she has pain or not, or if she's seeking for pregnancy, and the main reason for the consult.
Got it. So let's go down this road. Let's say, in this case, Doc, I'm 34 years old. I've been trying to get pregnant for a year, and nothing's happening. My periods are usually light, but I get these horrible pains like 3 or 4 days before my period. I've been going from one place to another for the last few years, and they just keep telling me to take birth control pills, but I want to get pregnant. How can I get pregnant if I'm on birth control? What do I do? Like, how do you approach this, for example, a patient like that?
Perfect. The first thing to know is to ask her another kind of symptoms. For example, if you have pain only during your bleeding or in another part of your cycle, if you have bleeding with intercourse, if you have pain with intercourse, if there's a specific position that you have pain with intercourse, if you have pain while you are going to do number 2 in the bathroom, if that pain is worse when you are bleeding or when you are regular
throughout your cycle, and also when you're on your period. Exactly. Is it worse with your period?
Yeah. Exactly. So you need to address if the symptoms are related for that. Also, if you're bloating, if you have distension on your belly, if that distension is all the month or just related to the bleeding, when you have pain, you need to stop what you're doing. you cannot go to work, you cannot go to school, you cannot go to university because you have this pain. You need to lay in bed how many days? 1, 2, 3. What do you take for the pain control? You take only Motrin or ibuprofen, you're taking something stronger, you take opioids, or you just stay antispasmodic, or how often do you take it? For how many days? For how long? How many years? If it's worse now than 10 years before, when you're taking OCPs, the contraceptive pills, it's really, you have relief of the pain or not? So all that answers is gonna lead me of probably what I need, what's the patient situated.
Yeah, and there's a few things that can do that, but for sure that is where people start, is with the history and physical. No matter what we do, we always have to start with the history and physical, but especially with that bleeding and that pain, because it takes so long to get a diagnosis. A lot of these patients even normalize the pain. They say even it's not that bad, but I think it's normal to be home and they can for the first 3 days of the period or a few days before their period to not get out of bed. And it's normal for them sometimes.
Especially Latins has this culture that you need to suffer, you know? The pain is like a normal thing in your life and you need to go for that. We fight a lot on the Argentine Society of Endometriosis. Pain is not normal. If you need to take more than 1 to 2 pills of AIDS or ibuprofen or whatever, and the pain is bad, and that's not normal. No one can tell you that's normal because it's not. And you need to assess that. You need to address that. So the first thing is go to your gynecologist and start seeking for answers for that pain. And if he tells or she tells you that this is normal, change it because this is not normal. And another thing is that after you speak with the patient and you go through all these steps or the history that you are making, a good thing is to examine the patient, because the vaginal exam can tell you a lot of information if you're carefully and you know where to seek. So after the visit, you could have a lot of suspects or suspicious of this disease just for the consult. You don't need anything else. You don't need any images. And even all the literature says that you don't need anything else to treat a patient suspecting endometriosis.
Yeah, so in general, when a patient comes to me, for example, for that, we're very lucky that we have very good ultrasounds in the office, and all the doctors in our office do ultrasounds. So a lot of our physical exam is with an ultrasound, and which has an advantage to it,
of course,
because there's a whole, right now there's I think a big revolution happening with endometriosis, where they used to tell you you need a camera in your belly to diagnose it. That's still the standard, but there's many ways now to catch it with ultrasound. I know like Matthew Lombardi in Canada has a bunch of papers put out on this, on being able to look at the uterosacral ligaments, being able to do a thorough exam with the ultrasound probe to see if anything sticks. There's something called the digital test, if there's sliding pain, that can give us a lot more information. And if no one's doing that, I recommend going to someone that does, because there's a lot more things that can be picked up. In a routine scan, they tend not to do that. So there's centers that specialize in endometriosis that are better for looking at those things. And if not, there's some places where they prefer MRIs for imaging. But like you said, none of these need to be done before even starting treatment, but that also depends on what the desired outcome for treatment is.
If the patient really wants a pregnancy, of course, I try to divide the treatment like in 6 steps. The first line that every single pain, chronic pelvic pain, in a patient suspicious of endometriosis is anti-inflammatory treatment. I mean, and a good anti-inflammatory treatment, a well-placed pain control. You need to know how and when you need to take your pills and avoid the peak of the pain and then you take the pill, because it's not going to come back easily when you get the peak of the pain. So pain controls is very important. The diet that you have, the anti-inflammatory diet that avoid things that maybe feels you bloating. Exercise is very, very important, because with exercise you can strengthen your pelvic floor. Also, pelvic floor therapy is very important too. And then hormonal treatment. Hormonal treatment is probably number 5, and I tell you that probably surgery is number 6. So if a patient really wants a baby and she's eliciting a lot of pain, we need to check on this if we are doing well the first 4 steps. If we are address that very good.
Yes, and this also goes into, I just did an interview with Dr. Bartos talking about the original fertility workup. Because yes, surgery is not the first step for endometriosis, but for example, if the endometriosis blocks the tubes, that's a very big change in outcome and story. And depending on where the tubes are blocked, it may require surgery versus some other sort of treatment. What steps would you take if the tubes were open and she's desiring pregnancy and there's no issues with the fallopian tubes, with the uterus? Is there any, let's say they tried a few cycles, let's say that they're a year in and they haven't gotten pregnant.
1 year?
Yes. Would you go to surgery? Would you recommend something else? Would you recommend IVF?
No. In a patient with endometriosis, after a year of before 35 years old and after a year of seeking for pregnancy,
6 months,
I would recommend IVF, unless this pain is for her is like affecting very much the quality of life.
Got it. So, because I know it's there's some people that are more rushing towards surgery and not, but assuming there's no cysts and they're not very large, what is the role of like a procedure like a butterfly peritonectomy?
I'm very into, when I do this lecture for the fellows, I always put the same patient with the same symptoms and images, but different ages. It's not the same at 23 that at 40.
Got it.
Why? Because at 23 or 25, maybe the surgery could improve the eggs
Success rate, the inflammation.
and also can achieve a better anatomy of the pelvis after the surgery. At 40, you don't have time to do surgery and then wait 6 months and see if it did help and then do, for example, an egg retrieval. So I recommend all the time to do after a year in less than 35 years, and after 6 months and after 35 years, I recommend try to go to IVF. If the pain is very important, try to do egg retrieval first and then the surgery. And the surgery shouldn't be a surgery just to diagnose the disease. The surgery should be as complete as possible, because what we try to avoid in the patient is the multiple surgeries that they have when they came to the office. Because everyone, she has pain, surgery, and I biopsy.
Look, I personally love doing surgery, and these patients, I send them to you because to do that specific surgery, it requires a great amount of skill, and you also don't want to mess up someone's fertility, and you want to give them also the best fertility outcome. And a lot of, as you know, with endometriosis, a lot of what is there is under the covers, meaning there could be something deeper in the pelvis that needs to be taken care of, or sometimes even something in the bowel that could be missed. So if you go the surgery route, it's really important that you have a good team from a diagnostic point of view and a surgical point of view if you go that route. And if I'm understanding you correctly, the role in surgery for fertility sparing is a patient that is younger. How old, what was usually your cutoff?
I mean, less than 35, 34 years old, that you can see something in the salpingography, that's some mild obstruction, or just you think that you could help her restoring the anatomy, to give her a little more time for natural pregnancy instead of just going to IVF. Of course, if we are talking to a patient that have a good quality of life with the disease, and not the patient who's really in really bad pain, because patients with really bad pain and there's refractory to the medical treatment, sometimes they need surgery. And at that point, you need to do excision of all the lesions possible of the disease.
Yes.
I'm sorry, last thing, if she had a cyst, for example, 3 centimeter cyst, that's the main concern.
Cutoff. Yeah, it's usually
the cutoff and stuff. Of course, cysts are known that they have like a toxic environment for ovulation, endometrial cyst and stuff. But sometimes when you try to do the stripping, the take out of the capsule of the cyst through the ovaries, you're going to take out normal follicles on that procedure. So the technique to do that is very important, but just in the best hands, you probably lose some ovarian reserve after surgery. So it's very important to do egg retrieval first if you have the possibility to have some backup.
Yeah, but yeah, it's usually why some people will try to take every cyst out. I think they recommend from like about 3 centimeters or less to not touch them.
Yeah. I mean, the to operate or not operate is like the
question.
The question, but if the for specifically for pregnancy, seeking pregnancy, if we are talking about that, IVF prove more reliable results than surgery.
Yes.
For that. So.
Great. So I think that really covers a patient coming in with a high suspicion of endometriosis. I think we covered so far that we do not need to do a diagnostic surgery for endometriosis.
Exactly, that's the old gold standard.
Yes.
We don't want that.
Yes, if they're young and in a lot of pain, you'd consider surgery, but otherwise we try to avoid surgery. And if they're over 35 or so and not in a lot of pain and don't have a lot of disease, it would make more sense to go just through the fertility route.
I try to take my patient and lead my patient for that, but I think that the rate of access is higher than try to do surgery and wait and then do the IVF.
Okay. So
I work very close to the REIs for each patient and discuss the images of what they have, if they are comfort to do egg retrieval with the big cyst and stuff. Mm-hmm. And the other big part of this is the pain.
That's also a multimodal approach. Pain is a very complicated subject and sometimes takes a team of people. Like I think you briefly mentioned before, like a pelvic floor therapist, sometimes a psychologist, the gynecologist. People sometimes don't understand that it's a whole picture. And even you tell people, oh, go see a psychologist, and they say, what, you think I'm crazy? It's not what we're saying. It's really important to understand that pain, it compounds on each other. If you're in pain, that can create a psychological component that can create more pain. So making sure we're hitting this at every angle is so important for treatment management.
It's something that's called pain sensibilization. Mm-hmm. That's when you have a lot of pain during your life, the small amounts of triggers can elicit a lot of pain. And that's for that you need to treat with a pain specialist. Mm-hmm. And also, of course, you need to do therapy. I do therapy, I mean, for a lot of reasons, but I think if you have a chronic disease, that this chronic disease is inflammatory, recurrent, have no cure, can lead you very bad pain. Of course, you need to treat that psychologically too, not only medically or surgically. Mm-hmm. So I think, yes, nutrition is a very fundamental part for this also. Mm-hmm. I think it's very important that patient who has a lot of blood thing has a good connection with your nutritionist. Yeah. So yeah, you need a whole team for some cases, yeah.
So that's an interesting point as far as nutrition. What nutrition do you recommend these patients?
I would try to avoid all the triggers that could cause some inflammation, like gluten, if there's not another gastrointestinal dysfunction.
Like if they have SIBO or something.
SIBO, celiac, or just intolerance for regular flour. The patient has, they tell you when they eat triggering inflammatory disease, a lot of sugar and stuff, they feel very bloated. Mm-hmm. And of course the treatment is not like correcting the diet because the problem is besides that, but you need to take whatever you can mm-hmm. to get your quality of life better.
And it's an interesting point because specifically on the nutrition side, I think it's different per person. Some people I think tolerate gluten, some people have a little bit and they may not have celiac disease, but they're a mess. Some people can't tolerate a carbohydrate because they have a small bowel overgrowth. And a lot of these inflammatory processes kind of hit on each other. Anything we could suppress, if you already have inflammation from one point, if we can try to limit it from other areas, I think is also really helpful.
Yeah, and one thing that is very important, and we try to, the society try to demonize most of the time the hormonal treatment. Mm-hmm. But we need to know that this disease is hormone dependent. Mm-hmm. So the lesions grow, bleed, and get inflamed because of the hormonal stimulation. Mm-hmm. So it's very important that we address some kind of hormonal treatment. We will see if it's only progesterone, combined, a patch, an hormonal IUD, we will see after the seeking of the pregnancy which is the best treatment for them. But it's important that we tell the patient that they need to stay on one of these regimens to try to avoid the recurrence of the disease.
Yes, because like you're saying, by having a menstrual cycle with the rise and fall of your hormones is what causes the inflammatory cycle.
Exactly, and when we prescribe hormonal treatment, we are going to lower the hormones, not to give more than the expected, because people think that you fill me with hormones. I just actually lower them down a little bit to avoid these implants or this tissue to grow up or to bleed or to have more pain.
Which is also interesting because even like the higher hormone pills, you look at something like Yaz or Yasmin, given the oral estrogen actually sucks up a lot of the hormones, which is why it helps with the acne and the other things.
Yeah.
And it keeps your levels super flat, so you're not getting the oscillations. And I know there's a lot of pushback against hormonal contraceptives right now. And for some good reason too. We're not saying that everyone should be on birth control. We're just saying that nothing's perfect, but specifically for these people, it can really increase their quality of life. Like, same thing, I don't think antidepressants are amazing for everyone, but for people that are depressed, it can really give them part of their life back.
There's a study that shows that if you, for example, a patient goes to surgery for an ovarian endometrioma, for an ovarian cyst, the recurrence of that cyst yearly is almost 30% without any treatment. But if you get in the treatment, it's 8%.
That's a huge difference.
That you can reduce the recurrence of the disease. It's not a magic pill, and of course you can get recurrence and you can still have pain taking them, but it's like a thing that we need to address and we need to tell the patient. As hypertensive people take an antihypertensive medication, hormonal dependent disease requires most of the time hormonal treatment.
Great. So we talked about people in the younger age range trying to get pregnant. Say now we have a 45-year-old patient that is done childbearing. They have horrible periods that start unbelievably bad pain to the point where they even have like pulls of constipation, diarrhea related to their cycle, pain with sex. How do you evaluate that patient, and would you do anything different between that patient and the one trying to get pregnant?
I mean, for the patient that is trying to get pregnant, I will do all my efforts to try to get that done as soon as I can, because time is important for ovarian reserve.
Yes, and also the ovarian reserve for these patients a lot of the time is lower.
Exactly. So in a patient that has the fertility accomplished,
they're done childbearing.
Yeah, they've done childbirth. Yeah, I will try the same things that I told you before, the same 5 or 6 things. But if the pain is not responding to all the medication, to all the treatment and stuff, yeah, I will definitely try to do a good clean surgery to remove the most of the tissue. Of course, after the surgery, they need to continue all these 5 or 6 steps that we discussed before. Yes. So the surgery is just like a thing, but it's not the cure because it's a recurrent disease.
Yes. And also, let's take this stepwise. Let's say they did birth control pills, and let's say they're not fully helping with the pain. Is there any steps you would take between there and surgery?
Well, of course, I will try a different hormonal treatment, because not every hormonal treatment are for every patient, and you need to targeting. For example, if the patient has adenomyosis, that it's a condition that affects the uterus, the muscle of the uterus, and it's very frequently associated with endometriosis, probably they are gonna benefit better with an hormonal IUD than a pill sometimes.
Yeah, I agree.
If the patient, I don't know, has a lot of androgenic issues, probably progesterone with high anti-androgenic effect is chosen.
What about, is there any role for like these antagonists or agonists like Lupron with add-back therapy?
Yeah, in the refractory cases, sometimes we use, it's an alternative. We have some progesterone in South America that it's approved and here it's not, and that it's a Dynagest alone. We use a lot, and it has, like, in a lot of studies, like the same pain control than Lupron.
Oh, which is better.
With even a very fraction of the adverse effects.
Yeah. And why don't we go for these first? Just explain to them like the risks of just shutting your hormones down.
I'm sorry?
Like there's risks of just shutting your hormones down with something like Lupron or with like my family.
Well, I mean, the Lupron, it will cause that all your hormones go very low, induce like a menopause, and you probably will have the effects of a menopause. But if you have scarring tissue, retracting nerves and structures, even if you do Lupron, this structure that it's taking your nerves from a side and doing scar tissue on your
pulling,
pelvis,
it's like on tension almost.
it probably won't take it out. Yeah. So that's the role of surgery over there.
Yeah, so I kind of just wanted to go into the fact, hey, if you're, let's say, younger, like 35, 40, I'm going to put you on something like Lupron for a long term. You're going to have the risk of having menopause early. And that can lead to cardiovascular issues, bone issues. And they always end up having to add back hormones anyways to try to reduce bone loss. So they have their place, and a lot of times they can help with pain control, but that is the limits to that.
The treatment for the patient of endometriosis is tailor-made.
100%.
You need to speak with the patient, see what she wants, help her. Which of the different trials help her get a better quality of life or achieve their goals. So I think that's why the first consult of a patient that they send me, for example, for endometriosis, maybe lasts 45 to an hour, because you need to address a lot of things.
I wanted to go through some of these different issues and change them. So I wanted the patients to see what kind of pushes us one way to the other. Because, you know, they go into these societies, have these big groups of people with endometriosis, and they can have one person say, hey, they just put me on birth control pills. Hey, they said surgery. And a lot of times it's not just a single box. Like you said, it's tailor-made. But there's things that may push us one direction to the other, depending on your symptoms, where you're coming from, your extent of disease. I just kind of wanted them to hear, hey, maybe age plays a factor, maybe your symptoms play a factor, maybe the extent of your disease plays a factor. Are you okay with a hysterectomy because you're older? Because there's some, we'll talk about as far as more definitive treatment, that is also, there's different things that go into that. Also, do you have pain all the time, or just with sex? Or just with your period? Or just with, they kind of push you one way or the other. So what would, with someone older, would you say would make them a better surgical candidate for the pain symptoms?
One of the most important parts is if the patient has history of surgeries, because most of them has.
Yeah.
And most of the patient of 42, 45 years old that has a long history of endometriosis have 2 or 3 surgeries.
Yeah.
So if you're going to plan a surgery for them, you will try to do the last surgery.
Yes.
So that's why the concern of hysterectomy is made in the talk that you talk with the patient. Another big professor that I have, Dr. Umberto Renisi, always says, try to avoid the hysterectomy with the conservation of endometriosis. Because if you take only the uterus and you leave all the tissue back, the pain is going to be still there. So as we spoke, it's very important to consent with the patient. Hysterectomy is, of course, is a part of that, because all the uterosacral ligaments could help. But when you leave the ovaries, you can still get the hormonal simulation of the lesions.
But that is the most definitive treatment, is to take the uterus, cervix, the fallopian tubes, the ovaries, and the peritoneum around it. And I think that last part, the peritoneum around it, is sometimes not always addressed. Even if you take your ovaries, if you're young, you're going to need to be on hormonal therapy anyways, and that is for 2 reasons. But in this case, it's not for actually endometriosis reasons, because you have no hormones, but it's for the other reasons of preserving your bones, preserving your heart, and to preserve your quality of life.
At the end, is at that age, the most important part to address is the quality of life.
100%.
So we will fight with you. No, I say because you made a team with the patient.
Not
exactly.
Yeah.
So we fight with you through this disease to get a better quality of life, and we are going together and see what we need to address to get this disease or a good quality of life for you.
Yeah, and it's very specific, like you said, when you put the consent on the table, and that it has to be a very specific procedure, specific consent for the patient that you're seeing in front of you. because sometimes these surgeries are not very extensive and sometimes they are very extensive.
People should know there could be complications.
Yes, they need to know if there may be a bowel resection in the surgery.
Or a complication of the urethra or a urinary complication, because the anatomy is so distorted that sometimes you don't find the structure where they're supposed to be, or they are with a lot of fibrosis or scar tissue around, and they can be damaged when you try to separate them from the inflammatory tissue.
Yes. And yes, complications happen, but also that's why you have people with good training. Not that they can always be avoided, but can at least have a higher chance of catching them when they happen and to fix them appropriately. And that's a very big thing to be aware of is, yes, if you have, let's say, a bladder injury, that's bad, but if it's fixed at the time, the complications are very different than if they're not.
Of course, yes.
So we'll go into that. I think that's a good overview of endometriosis. Also in South America, I know we have a lot of patients here that have a lot of C-sections, and we're talking about fertility and bleeding. I thought it would be really good to also talk about isthmoceles.
Yeah.
So, what is an isthmocele?
An isthmocele is a defect on the scar of the previous cesarean or C-section, where most of the time could do a cavity, a small cavity that could retain blood from menstruation, blood from your period, and that blood gives you very uncomfortable because after your period probably you could have 5, 10, 12 days of spotting after that, or could be an adverse environment for an implantation of an embryo for a second pregnancy.
Yeah, and it's something that we see more and more, especially in this country. I'm sure in Argentina it's the same way. There's a lot more C-sections being done. Sometimes when I get patients, maybe 6 months, a year later, going, every time I have sex, I bleed. I have my period and then I bleed for all these days. And you'll look at them, they don't have any risk factors for cancer, they don't have any risk factors for any of these things, but they have this non-stop bleeding. Their pap smear is normal, and all of a sudden they get evaluated by the right person, they get an ultrasound done, and they see a small defect in the lower uterine segment where this previous C-section was. The question is, how do we manage this?
That's a good question. Well, you showed me a case the other day that has a very large defect over there. The most important thing to address in a patient that you see an isthmocele by ultrasound or MRI is if the patient has symptoms or not has symptoms. If the patient is completely asymptomatic, there's nothing to do. You leave it alone, there's no problem. Of course, infertility is like a symptom for us. Yeah. So if it's infertility, we go to the other side. If we have symptoms or infertility, we need to treat that.
So let's go into, let's stay on the fertility topic. Let's say they're asymptomatic and they have an isthmocele. They clearly had a baby before because they had a C-section.
Of course.
Right? So we know it's likely not something else, because some people ask, okay, I don't have symptoms, why is it this? It's true it could be other things, but likely if you had a child previously, your tubes are open, if you're with the same partner, everything was previously working.
Exactly, you shouldn't have any issues for that.
So if you have a patient in that situation, what is the next steps forward?
Usually with the patient with isthmocele is usually it's a referral from REIs.
Yes.
Because REIs get the patient, treat the patient, maybe a couple of cycles of IVF, even if they see a small isthmocele, and then the treatment are not working, the patient is not getting pregnant, or the symptoms are worse about the bleeding. So that's when you try to correct the defect. And there's two ways to correct it. By the vagina, in something that you call hysteroscopy. Then you get a camera from the vagina, the cervix, and then the uterus. And what we try to do, when you see the tube, because inside the uterus you will see like a big cylinder, a big tube. In the anterior part of this tube, you will see a cavity, like a triangle cavity like this. Okay, so that cavity retains the blood in this manner. So what we try to do hysteroscopically is try to remove or to get this cavity more plain, so more round.
Shave the side.
Exactly. For example, if the cavity is like this, I will try to get it like this. So the blood could flow and does not get stuck over there. After that, there's another technique that called 360, because not only you resect the flaps of the edges of this triangle, not only this, if not, you do a coagulation of 360, because when you have Isthmocele, you most of the time you have abnormal vessels, abnormal arteries or veins over there.
And they get a lot of pelvic congestion
that can contribute to this topic.
So you do not only the isthmocele around almost the lower uterine segment.
You do a 360 on the cavity, a 360 rollerball coagulation for that.
And that's just by the lower uterine segment, right?
Yeah, exactly. At that point, at that time, and at that moment.
So I wanted to talk to you about this because there's two main approaches to this that we see, which is the hysteroscopic approach and the laparoscopic or robotic approach, or I guess technically an open approach. I was always taught, and I saw the laparoscopic approach. I know in South America and in Europe, the hysteroscopic approach is more prevalent, and we're seeing it more and more in this country. So it's really hard for me now trying to refer out, because when I used to just tell them they do laparoscopy, they'll fix the defect and do that. That's changed, and we've gotten better. When would you do something hysteroscopically? When would you do something laparoscopically? And is there any side effects, good or bad, in both ways?
We need to remember that usually the Isthmocele, the patient who has the Isthmocele is because they can. Why I say this? Because as the same patient that has, you use exactly the same scalpel, yes, and the same suture in the skin, mm-hmm, and one patient has a keloid scar and the other one has a perfect clean scar. Mm-hmm. Okay, this is the same.
Is there any difference in surgical technique that you think that makes a difference?
There's a lot of information about that. There's a lot of studies about that use different type of suturing, 2 layers, 1 layer. When they close the C-section, the uterus, and there's nothing like.
Yeah. I ask because also, for example, in here, especially in New York, we get patients down here. Some places won't VBAC a patient if they had a 1-layer closure on their uterus, but the studies show no difference between a 1 or 2 layer closure.
So that's why I think it's more like a inflammatory reaction of each patient to the suture. So that's why, taking that in mind, and I speak this with my patients all the time, remember that if we are going to do some open case, we are going to correct the defect and put suture again. Mm-hmm. So you may have a recurrence because we are putting suturing again. Mm-hmm. Of course, most of the cases has a good outcome, but you need to tell them. So sometimes it's better do a trial hysteroscopically, and if that doesn't work, try to do the laparoscopic or robotic approach. But if you have a myometrium, so the muscle of the uterus between the cavity and the end of the uterus, the serosa, is less than 3 millimeters. It's very, very, very little. You probably don't get a good result doing the hysteroscopically, and you should go forward to the...
Because you can't shave it down and flatten it. There's nothing to shave down and go through it, and it causes a bigger problem.
Exactly.
So the question though is, if you're leaving it open, wouldn't, like we talked about risk for next pregnancy, wouldn't there be a higher risk?
If you leave it open, what? Sorry.
Meaning, if you do a hysteroscopic resection and you're not basically taking out the isthmocele and sealing it, is there any difference in C-section scar ectopic pregnancies?
I mean, there's no many data about it. There's no many information about that. I mean, the correct approach and the recommendations are, if there's more than 3 millimeters, I think it's a good approach. You have still a little bit of myometrium over there, and as a woman that has 2 C-sections, yeah, of course, there's an increased risk of rupture. There's an increased risk of probably a scar ectopic pregnancy, but that's the risk of any patient that has some scar in the uterus.
Yeah, but we don't know if it's making it worse or not. And I'm saying that too because my gut reaction was, why would we do that? Why would we open that up? But I think you explained really nicely that even if we took it out and put it back together, because there's an issue scarring, it's not like the likelihood of it being closed when you go in to do, say, the IVF people sent you to do another IVF cycle, is still very high. You actually may make it worse because now you're opening something completely, which is something like for me when I learned about it was really interesting because I always thought, why are you making a bigger hole for something to go there? why are you making it bigger? But you're not. You're kind of making, you're kind of, if you had a bubble of blood, you're taking that bubble of blood out and flattening it, so the toxic of the blood isn't affecting the pregnancy.
And also, you shave the edges, but not the top of the triangle. So for that, you get a more smooth surface for that.
Yeah, so the surface is smoother. The goal is for nothing to implant there. And honestly, if something implants there anyways, we have bigger problems.
Of course.
And
Yeah.
in general, the chance of having a placenta accreta spectrum is quite low unless you have a placenta previa, which when we're talking about IVF is higher. This is why it's really important to have a full team of people, including the reproductive endocrinologist and your normal OBGYN, because these are increased risks when we're moving forward to know, hey, is it safe to have another pregnancy? Are you okay taking these risks forward?
As we start speaking, and I know because I spoke to you many times, you think the same with me, all the treatment for the patient should be discussing in the table,
Yes.
counseling, you could have this, you could have that. What I think is good for you is very important, because I saw a physician that just show them the different treatments.
Yeah.
and let the patient decide. But you should say, I think this is the best for you because of this and that. And also, I think it's a good way for our patient that knows that here in our offices, they can have this kind of support for every treatment.
And I think it goes back to this informed consent. If you're going to do something, because these are surgeries, remember that it's something with your body, it may be the best thing for you, but there are risks, and you should know what the risks and benefits are going through it, and understand too that your doctor knows what they're talking about and are safe doing these procedures moving forward with you. And understand that there are different options. Anything else you want to add?
No, just thank you for the space. That was a really good chat with you.
Really enjoyed it. Thank you, Santiago.
Thank you, Mitchell.